I say this kind of jokingly because I'll get guys who are like, Doc, I'll do anything. I'll do anything to get injected, to have an erection again. Like, you just name it, and I'll do it. And I'm like, well, will you inject your penis with a medicine? And they're like, no. And I'm like, well, you really weren't willing to do anything.
Welcome to the Invigor Medical Podcast, where our mission is to provide personalized medical care through scientifically backed education and wellness solutions. All right, we are here with the Invigor Medical Podcast with Dr. Josh Spendlove MD. Josh, how are you, man?
Hey, I'm doing well. How about yourself?
I'm doing good, thank you. Thank you for joining me. This is really awesome. You're one of the first guests to come in studio. This is
cool.
Awesome. So
this is quite the setup here.
It is a nice setup, but we're here to talk about you and what you do in medicine and all that good stuff. But the first question that I like to ask all my guests is, why medicine? What in your mind happened and you said, yes, I'm going to go to school for a very long time and I'm going to help people? What was that?
Well, it's funny because, you get that question a lot, especially as you're going into medicine and getting accepted in med school and residency. Mm-hmm. But, I wish I had this really cool altruistic story, but just kind of growing up, going through school, I always loved biology. Those were my favorite subjects, especially human biology. I just thought I was just fascinated with it. And then I remember my dad, just with his career choice, there was always these concerns of layoffs.
Yes.
And
yep, I lived through that.
And so I remember, I don't remember what age, but it was really young, probably way younger than I probably should have been thinking about these things. But I remember watching the news, and I'm like, you know what? I never hear or see about unemployed doctors.
Nope.
And so
there are lots of people out there messing things up. So
exactly. So I just remember wow, what a life to have there, where you don't have to worry about being laid off and are always kind of looking over your shoulder or looking for a new job. So that's what kind of got me started. And then I just continued, and I enjoyed learning all that stuff. So going to all that school for that long really wasn't that big of a deal.
Really wasn't that the hardship that most people think when they go to school?
No. Not if you enjoy it. I guess anything, if you enjoy it, you'll put forth the effort.
Why urology, though? What landed you there?
Good question. So this is a little complicated here too. Mm-hmm. I always knew I wanted to do surgery. I loved working with my hands. I love the thought of being able to go inside somebody and fix them and sew them back up. I was...
that scares me. That's awesome that you're like
exactly.
that.
Exactly. I'm fascinated with that the power to do that and the ability. And you look at those people and you're just like, oh my gosh, how do you do that? So I was always fascinated with that. When I went into med school, I thought I was going to be a general surgeon. Okay. And as I started doing that and was going through what are called rotations, mm-hmm. I realized that, wow, these guys are on call all the time.
I've watched Grey's Anatomy once or twice.
Yeah. And they are super busy. And I quickly realized that wow, I don't know if this is quite the life for me. And then I just happened to, so I was in med school in Nebraska. Mm-hmm. And before, probably about a couple of years before med school, I started getting into rock climbing.
Oh, nice.
And so when I went to Nebraska, there's really nothing to climb. But there is at the University of Nebraska, Omaha, there was a rock wall. And so I started going to the rock wall and then climbing. And then it turned out I met a guy who was a urology resident at the hospital, and he was just really excited about urology too. And when he heard that I was a med student, he was all about, hey, why don't you come shadow me? And at the time, I thought urologist, all they did was deal out, erectile dysfunction pills and
that's
and checked a bunch of prostates. I had no idea that they actually did a lot of surgery. Mm-hmm. And so I started following him around, and I was realizing that, wow, you guys do a lot of surgery. This is really cool. And then as I started looking into it more, and I'm like, there's definitely a few urology emergencies, but nothing like general surgery. And most of the people I talked to, they're kind of had the nickname of the happy surgeons because the urologists really weren't on call all the time. And so it was
a smart choice to make if I'm hearing you correctly.
Apparently, but so you say that, but it's really weird. Every year there's a company called Medscape that does, was it Medscape? No, I don't remember actually who did the survey. I think it was, actually it wasn't, because I had a bunch of other career paths. But just this year, I guess urologist was voted or ranked the highest, most stressful job.
Most stressful? Yeah. Oh, geez. I guess with what you're looking at sometimes.
So yeah, I was like I'm like, well, maybe I can kind of see that. But anyway, so I started following him and realized that like I love the surgery part, but I don't want to be on call all the time, so I matched into urology. And I think the other part too is that it's really specialized. Like there's not a lot of them. Yep. Like you go to most programs like that train doctors, and there's usually like for every year there's like 10 to 15, sometimes 20 general surgery residents. But usually with urology, there's like maybe 2 to 4 every year. Wow. So there's not a lot in the country. And I kind of thought about, it's kind of nice to be something that's selective, that's small.
Well, yeah, I mean, you keep talking about surgeries. What surgeries have you done? Have you done transplants?
So I did it as a resident. Yeah. So there is a couple of career paths that a urologist can take. But some programs will do kidney transplants.
And you've done those?
I've done those as a resident. Granted, I'm not, responsible.
Stop playing it down. You were 100% in that room working on someone with your hands in them. You were part of it too. You were awesome. That's awesome.
Funny. One of the coolest parts was going on around the procurement. So you're hopping on this like private jet and you're, jetting off to
go get the kidney.
Go get the, or harvest all the organs and come back in. You're riding in an ambulance. I thought that was pretty cool.
That's pretty nice. You got to do where they fly you to. I mean, it's kind of weird. You're flying somewhere to pick up a kidney.
Yeah,
but.
I think when I was in Nebraska, I think the farthest I ever went to was not that far, Chicago or something.
Okay, yeah, not far at all.
So not very far. But so other surgeries, I take out kidneys, so nephrectomies. Traditionally, a urologist does like a prostatectomy, so prostate removal for cancer. I don't do those just because it's a very specialized procedure and you need to do a lot of them. But I do probably the most things that I do are kidney stones.
Ooh, how have you had any real rough ones of those?
I've never had kidney stones. I treat, I probably do 2 to 4 a week.
Do you have to pass them now still, or do they use the shockwave stuff to break them up?
So shockwave is actually kind of older technology. What we do now is something called ureteroscopy. So it's tiny, exactly. Tiny little scope that goes in through the urethra, bladder, up the ureter. That's the tube that connects kidney to the bladder. And we go and have a little laser. It acts like a jackhammer, break up the stone.
Makes it way easier than it was back in the day.
So, there's pros and cons. I mean, it's probably a little bit more uncomfortable to go through, but we have a better chance of clearing out all the stones from that. But I do incontinence surgeries, so...
elaborate on that. What's that?
So, like, definitely more common with women, but so, like, leaking with, like, coughing, sneezing, laughing, stuff like that. Okay. So we I'll put in different types of slings. And then men will also have issues with incontinence, so I'll do these... call it a TERP, or the lingo is a Roto-Rooter.
Roto-Rooter?
Yeah, so go in, kind of remount the prostate so that it's easier to pee.
Oh, Roto-Rooter. I'm not sure I ever want to go through that process, but if I need to, I'll give you a call. So you do obviously supply the ED stuff. Yep. We have Tadalafil.
Okay.
We have PT141 for the women's libido. What percentage of your patients are women, female, or men, female?
So I probably see maybe 60% men, 40% women.
More of a problem in men usually.
Prostate,
obviously.
Yeah, so definitely with like prostate issues and stuff like that. And then as far as the sexual component to it, I think most women end up going to their gynecologist for those types of things. I see a little bit of it, but not a whole lot. I typically see more men for issues with sexual function.
ED. What do you subscribe for ED?
So I usually tell patients I kind of have 2 pathways. I have their traditional pathway, and then there's kind of the non-traditional pathway. So the traditional pathway, we begin with lifestyle changes. Yep. So we say things like, really, I really harp on sleep because there are some great case studies as well as some data that shows that sleep is essential for testosterone production. Okay. So I tell guys that, you really need to be shooting for 7 to 8 hours of sleep. Okay. you have to, whatever it takes to lower stress in your life, whether it's altering your job hours, whether it's meditation, whether it's finding a hobby, some outlet so that you can decrease your stress.
Climbing rocks
or what have you, working on cars, running, whatever it takes. And then exercise. I'm really big proponent of resistance training.
Okay.
So big
Band training.
Big compound movements like squats, deadlifts, things like that will raise testosterone. And then, diet and exercise types of things. So once we've really focused on the lifestyle, then we'll go into the pharmaceuticals. So there's the PD5 inhibitors. They all work pretty much the same. There's some differences with them, but generally I find that if a patient, like if one, for instance, doesn't work, it's not real typical that another one will. But, sometimes we'll cycle through there. But I usually use the common ones that are generic, so tadalafil and sildenafil.
Okay. Yeah, we have those.
I usually start out, I don't really start low and go high. I usually, start high and have them either like break the pill in half. Like, so if there's a 100 milligram sildenafil tablet, I'll usually have them break in half and go from there. Or if it's tadalafil, I'll do the 20 milligram tablet and have them break it in half. The guys that have some urinary difficulties, I'll do it like a daily tadalafil.
Wow.
So there's an indication to treat lower urinary tract symptoms.
So benefit there too.
So, and then there's some others that, to be honest with you, I don't think I've ever prescribed, like Levitra and Stendra.
Well, from my understanding, there's quite a bit of options out there for that stuff now.
There's definitely more out there. I'm sure it's more expensive. I mean, I haven't looked at this recently, but I don't think any of the literature shows that any one is better than another. I think the claim to fame for Stendra is like a 10 or 15 minute onset. I usually tell patients, what are you looking for? So a tadalafil has a longer half-life.
Yeah.
So it's kind of like nice. You could take it on a Friday and, it's still in your system by Sunday. But I also tell patients, if you're going to have a side effect, unfortunately, sometimes that side effect is going to be present for longer as well.
Okay.
So headaches are pretty common, really bad nasal congestion. Some guys will have like body aches. And then there's the sildenafil, which has a shorter half-life. So if you're going to have a side effect, it's kind of nice where, maybe you're only going to have a headache for, 4-hour period of time.
Yeah.
Type of thing. The unique thing about Viagra or sildenafil is that it can actually cause a blue tint to your vision.
Really?
So I'll tell patients, don't get too worried when it's almost like you've got a blue, like a pair of glasses with a blue lens
on them. Really?
Yeah.
Wow, I did not know that.
There's one of the same enzymes, the cyclooxygenase, is found in the retina. And so you can mess with the I don't remember if the rods or cones. Back to
has anybody ever called you after they got that prescription and been like, blue, man, it was weird?
I've never had anybody like really get worried about it, but I did have one guy that after I told him that, he's like, oh, that makes sense. Like I thought that my eyes were like playing tricks on me or something, and
it did happen.
And so it did happen. But then after, if those medicines don't work, it really depends. Like if you've got a guy that's somewhat healthy, that's not, morbidly obese, who's in his, 50s, maybe early 60s, generally they'll have pretty good luck with those. But if I got a guy that has like a really brittle diabetic who's, there's definitely some guys where you look in there and they're struggling just to breathe, just being in walking up the stairs to get to your office or something. Typically, they're not going to respond to the PD5 inhibitors.
They've got enough stuff going on in there that's messing it up.
So for the next step, and I'll throw in things like there's a vacuum erection device. Couple that with like a cock ring or something like that. But to be honest, I think I've only had a handful of patients who have actually repeatedly used a vacuum erection device, a penis pump. I mean, it's not real natural. It's kind of uncomfortable.
At least you give them the options. I mean, a lot of doctors in situations like this would just prescribe and say, get out of my office.
Yeah. I mean, and then oftentimes you'll combine it. So you can use the Viagra with the vacuum erection device or something like that. After that, it's injections. So penile injections, there's a bunch of stuff out there. Yep. The most common one is something probably called Trimix. And there's different, so it's 3 medications. There's prostaglandin, papaverin, and phentolamine.
Okay.
And there's different concentrations of each that the people will mix in. I don't know. I think don't you guys do?
We do have some, and we have some instructional videos also online that you can check out on YouTube.
How to do it, yeah. So I don't know what particular concentrations that you guys have or offer, but some patient might react a little bit better to one versus another. Like
usually the injection of any type of supplement is going to work a lot better than the pill.
It's going to work in like 90+% of patients.
Lots of side effects.
It can be. It's really funny though. I say this kind of jokingly because I'll get guys who are like, "Doc, I'll do anything. I'll do anything to get to have an erection again. Like you just name it, I'll do it." And I'm like, "Well, will you inject your penis with a medicine?" And they're like, "No." And I'm like, "Well, you really weren't willing to do anything."
Okay, so you've been in this for how long? Have you been in medicine?
So, so I graduated residency in 2014. So that's when I'm officially, be able to practice on my own. But I started this whole process in 2000, almost 2004.
10 years?
Yeah, I was in practice in New Mexico for a while, and then came up to Walla Walla for a few years, and then I've been here almost 3 years in Tri-Cities.
What in that 10 years that you've been in through school and through residency and stuff? What I would say crazy. But unique. What are some of the unique things you've come across? Like, I'll give you an example. We had a plastic surgeon on once, and he said that a deer went through somebody's front windshield. Now, I wasn't thinking that he would say something like a deer being a plastic surgeon, so I'm kind of curious to see what a urologist is going to say.
So, it's interesting because I do these surgeries, and for whatever reason, it drives a lot of attention in the operating room. Like, so when somebody, looks on the board and sees that I'm doing one of these surgeries, there's a lot of interest. So I do what are called penile prostheses. So it's it's a surgery for guys that have such extreme erectile dysfunction that they can't get an erection at all.
Okay.
So they're either unwilling to do the injections or they've tried them and they don't work. And essentially what we do is we implant a device inside the penis. So there's two kind of erection tubes that fill with water. So we implant that inside the penis. We put a little reservoir of water next to the bladder and then a little pump button in the scrotum. And essentially what they would do is they would squeeze this button in their scrotum and it transfers water from the reservoir into the erection tubes and you get an erection.
There you go.
So you get an erection as long, anytime you want for as long as you want. And then you click a little button and it goes down.
Okay, I had shoes like that in the 90s.
Like the Reeboks,
right? Okay, I was
very similar.
I don't want to make fun of it too much because I know it is a situation.
Very similar,
but I've never, ever heard of that.
Yep.
Now, are you at where you do the surgeries? Is it a teaching hospital or no? So they can't watch?
No, we've got the staff. So there's they're called the surgical techs and the operating room circulator nurses. Will always come down and have a little look. There's always giggles.
Curiosity.
Definitely a lot of curiosity.
Well, you're married. What does your wife say about it?
Kind of grosses her out.
Yeah, that is interesting. So you said lifestyle changes is the first thing you obviously suggest, and then after that you do the supplements. Have you had anybody try to self-help themselves to fix their ED without you know what I mean? Like people do weird things, like bee juice. I know it could work or something like that. Rumors. Yeah,
so I'll address that too. But there's also, so I had a guy who wanted to address premature ejaculation.
Okay.
And so he basically injected collagen into the head of his penis. And it's, I think I've heard,
That's the stuff that people put in their lips, right? To make it bigger? Okay.
So I had never heard of this, and then I kind of did a little bit of research, and I guess that, there are some people that do that to help kind of, desensitize the penis or something.
Really?
And also, I guess, maybe make it a little bit bigger or something.
Sounds uncomfortable.
He had a complication that I don't think it's very common, but it does happen where it can cause tissue necrosis. So if that collagen, blocks off a significant portion of the blood flow to whatever organ, it can cause the tissue distally to that to die. And so he had basically the top, several layers of around the penis that essentially died.
Oh man. So he didn't even help his own cause. He made it even worse.
Exactly.
I can suggest to anybody, don't do any of this medical stuff on your own. You've seen stuff about people trying to make their butts bigger or whatever by putting different things. Don't do it. Go to a doctor, please.
No. I've had guys with that are high, on meth and heroin did the vacuum erection device. and then they put like a cock ring there, and then, passed out or, whatever. And so, hours or something later,
that's not healthy either.
It really does look like an eggplant.
Oh, jeez. Did they have to come in and get it fixed at that point? Or?
So it really depends. Oftentimes, I've had, these are all kinds of weird stories. So we've had to put like special ring cutters, like how, sometimes in accidents emergency rooms, people have like a ring on their finger that they have to cut off.
Yeah.
So there's a special device for that. We've had to use those in the operating room to cut off different types of devices.
From the genitals.
Yep.
Ouch. Besides the tube, and I don't know if I want to know the answer to this question, what type of devices?
So, it was really interesting. So I saw this guy, I got this call from the emergency room, and I'm like, what? They're like, yeah, it's like some metal cage that this guy like.
Cage is the word they used?
Cage.
Oh, wow.
And so, I told them like, look, you're going to have to find some really advanced, because, they have like ring cutters that can cut through like titanium and stuff. So I'm like, you're going to need some really advanced stuff to cut through that metal.
Yeah.
So, we knocked him out and ended up cutting it off. But then, I went to, there's a adult novelty store here in town called Castle, and I'm in there, and sure enough, in one of the display cases, there is this, like, it's basically a chastity belt for men. And
really?
That's exactly what this guy had.
And he couldn't get it off.
He had kept it on like it way too long.
Like one of those Chinese finger handcuffs they had or whatever?
What typically happens is you start to get a lot of swelling that are distal or past where the constriction is, and so they try to slide it off, and they can't.
It just it's taking more than it should. So when you go to Castle, that's all work research, of course.
Of course.
So. Okay, so women, we've talked a lot about men and ED. You help women with low libido and stuff along those lines?
So I've done a little bit. It's really interesting. If you look at the literature, there's not great guidelines for like hormone replacement as far as like libido for women. I do think it was a huge travesty. I don't really necessarily want to go into this because I don't know the research very well, but there was a big study maybe 15 years ago that basically said that hormone replacement in women was bad.
Okay.
That it was associated with, breast cancer and ovarian cancer, and everybody on hormone replacement should stop immediately. And, they did some subsequent analysis of that study, and it found out that it was basically full of shit. Like they did the statistics wrong, and actually the hormone therapy was actually really beneficial for a lot of women.
Oh, man.
But unfortunately the cat was out of the bag. So now, lots of women that are going through, menopause have got these horrible symptoms, and they think that they just have to live with it. And a lot of like, primary care docs and, gynecologists think like, oh, we can't do hormone replacement on these women because, they're all going to get breast cancer and die. And so they're suffering, they're struggling, and, hot flashes, poor sleep quality.
And nobody's gone and turned this study over and gotten...
Oh, no, there's lots of people who have done it, but it's like just anything in medicine. It takes a long time to, it's slow to adopt and it's slow to change, and there's some good to that, but there's a lot of bad. And so that's one thing that's just kind of a pet peeve of mine that right now, like there's still not a lot of info out there showing that, women don't have to suffer.
Yeah, no, I mean, and to get the word out is the best thing. That's what we do here at Invigor Medical. We help people make decisions to have a healthier life, which is what you do because you're a doctor. PT141 is one of the things we have here. I'm not too familiar with it, but it is one of the options. You can go to invigormedical.com, check out all that stuff. Where can people find you?
So I am employed by Trios Hospital. So I'm at the professional building next door.
That's in Kennewick, Washington.
Kennewick, Washington, correct. Yeah, Trios Hospital, Southridge. I think,
yeah, Southridge, yep. What, you on social media and all?
So I am, but I don't have like just a personal account.
Just be like LinkedIn. Go to LinkedIn and find them on LinkedIn if you want to.
I mean, eventually, so I've kind of got these plans of I have this joke that I'm basically like a human plumber. And so
yes, yeah, you are. You work on all the plumbing.
And so I am working on like more of a social media presence, the human plumber.
I like that. I like that. We can work on a logo for you. What? If you had one piece of advice for somebody, I know you've given some really good nuggets so far. If there's one thing someone can do in their life, just blanket general, to make their life better, what would be your suggestion? Now, I don't want to put anything in your brain, but you tell me what you think.
Exercise.
Exercise, okay.
There are some amazing studies that show that the degree of muscle mass that you have later in life, as well as something called VO2 max, which is basically a way of measuring kind of like your aerobic capacity.
Okay.
So if you've got high aerobic capacity and you've got high muscle mass in your 70s, 80s, 90s, that is going to be way more predictive of longevity than just about anything else.
And that you see lower signs of ED and stuff like when people that exercise and are in shape and everything?
Absolutely. That's the first thing when a guy comes to me with erectile dysfunction, I'm like, you've got to move. You've got to lift weights. It's got to be more than just going out for a walk. I mean, that's great. But you just need to do more.
I'm going to take a note here. I'm not old enough to have that issue yet, I hope, but I am going to get a gym membership, and I am going every day because I don't want to have to live with that.
It's really interesting because I've practiced mostly in small towns, and I run across my patients so often in the community. And, I often feel bad when I ignore patients that walk by. And I do it for a reason because I don't want other people to be like, how do you know him? And then open up a can of worms that they weren't necessarily wanting to open.
That's smart.
But no, it's surprising how often I run across patients.
So you're saying some guy that might have gotten the Reebok pump put in? I don't know if I should say that or not, but wouldn't necessarily come up to you on the street and be like, hey, doc, what's up?
Exactly. Or, put something in the urethra and I had to fish it out, 3 weeks ago, or, so.
Did you work in the emergency room at all?
No, but when the emergency room, when patients come there and the emergency room docs are like, oh, I don't know what to do with this. That's when they give me a call.
How often does that happen?
Gosh, it probably happens. I probably get 6 or 7 calls a week.
Wow, really?
I mean, but it's more common things, not foreign bodies in the urethra. It's usually kidney stones or
like daytime stuff, not usually like.
There's a couple like at night some guys got a kidney stone at like 2 a.m. Then there's some other associated factors, and I'll have to go in and see them. But
okay, so one of the questions we get a lot on Google is vasectomies. Do they play a role in ED?
So they don't. So essentially,
I have one.
Exactly, I've got one too. So essentially, all we're doing is we're cutting the sperm tube, the vas deferens. So we're just making it so that sperm can't travel from the testicle out. So the actual component that the testicle provides for semen is very small. So there's not even really a reduction in volume. We don't do anything to testosterone production. The testicle is just fine. There's also kind of a caveat to that too, is that there's a lot of people, for whatever reason, there's been the thought of an association between vasectomy and prostate cancer.
Okay.
That one is not as clear. We think in general it's no, but if you scour the literature, there is some evidence to show that there might be a slight association, not necessarily causation, with vasectomy and prostate cancer.
Now, okay, is it weird that a wife would want to go in and make sure that the surgery was taking place?
You say that. I have had several times where, so I usually cut a piece of the vas, the sperm tube out, and I had one, oftentimes the wife is there in the room, so she wants to see it, and then I had one that actually wanted to keep them.
Keep them? Okay. No, my wife didn't want to keep it, but she definitely wanted to be in the room. All I did is smell something burning for a second, and I wasn't really happy about that. But okay, so vasectomy doesn't necessarily affect ED. There's still do the vasectomy and prostate. That's still kind of.
So it's I mean, overwhelmingly, like I recommend. Like I've had a vasectomy. I recommend doing it. But again, if you really like, I'll be honest with patients. Like I still recommend doing a vasectomy. Like I wouldn't do it because you're concerned about prostate cancer. But if you did kind of research on your own, I want to be very transparent and be like, look, there is some literature that maybe shows a little bit of an association. Okay.
Well, does testosterone, does that play a role in ED?
So it does. The role that it plays is actually pretty complex. And I'm really upfront with patients because a lot of times there's this notion that like, oh, if I've got low testosterone, that's the reason why I have erectile dysfunction. Yeah. If I fix that, I'm good. And unfortunately, it's not necessarily the case. for instance, there's often times where I'll treat prostate cancer, and one of the things we do is we cut their testosterone off. So we'll give them medication so their body doesn't produce it, and they could still get erections.
So it's like a testosterone-based cancer?
Correct, yeah. So it's testosterone has a weird role, but it can kind of feed it, the
estrogen
cancer.
feeds breast cancer and stuff like that, yeah.
So these guys that don't have hardly any testosterone yet, they're still having erections. It's really bizarre. Usually, if you look at the causes for erectile dysfunction, the most common one is vascular. Okay. So what tends to happen is the endothelial lining of the blood vessels that are in the penis, they're supposed to be responsive. So there's some signals from the brain that tell these blood vessels to dilate. So as they dilate, they draw in more blood. Mm-hmm. As the blood comes in, it actually compresses the veins that take blood out of the penis. So that's why you get an erection. Through the same thing with like cardiac disease, plaques and stuff like that. Yeah. You get blood vessels are not super responsive, and so they can't dilate with blood like they should. And so that's why you guys will not be able to have an erection. There is some issue too with the innervation of the penis and the nerves that help control erections. There's a thought that those nerves can sometimes be damaged, and that's why. But the number one cause of erectile dysfunction is this inability of the blood vessels to really dilate. Okay. What role testosterone plays is really not super well known. Like we just don't know, but we do know that there are many cases where guys that have low testosterone, hypogonadal, if we replace that testosterone, they can get erectile function back.
What would you what supplements and stuff would you suggest for that?
So with guys that have kind of marginally low testosterone, again, I'll go really harp on lifestyle. Mm-hmm. I've heard case studies of guys who are even like, bodybuilders, these extreme athletes that just kind of ran themselves down, that weren't sleeping very well. They were working out too hard, too often. They would get these testosterones where they have a total testosterone of like 100, 120.
And what are they supposed to have?
A guy in his 30s, like I would like his total testosterone to be 450, 500. Okay. His free testosterone, 12 to 15-ish. Is where I'd want it to be. So these guys are super low, but like they're these, they're athletic, they're built, and it's just from having their body run down.
Do you think that do steroids play into low testosterone?
It can't. Definitely with like bodybuilders and stuff.
Not saying that these people are on that, but I'm assuming.
Even a history of being on testosterone for a significant period of time, that the testicles basically say, hey, look, there's plenty around. We don't need to make it anymore, and they shut down. And oftentimes they don't restart back up. Okay. So it is pretty common. I'll see guys in their late 40s, 50s that are on testosterone because they abused steroids earlier in their life.
Yeah. What do you suggest naturally for people to do to try to keep...
Again, the lifestyle stuff but there's also there are some supplements. There's I'm blanking on the name now that we're here on the podcast. Tangat Ali, I think is what it's called. Okay. It has, depending on a few studies, I think I saw this first on something called the Huberman Lab, another podcast there, that there are some studies that show that it can raise testosterone by 100 to 200 points.
Oh, okay. That would double the
exactly.
gym guys.
And there's some evidence of these things like GNC and these other herbal supplements that they can modestly raise total testosterone.
Okay.
But
what about like food? Like any foods or any beverages or any type of...
No, I mean, there is some thought that anything that increases blood flow or nitric oxide. So there is this thought that like beets have high nitric oxide.
Yeah.
And I think there's a beta-alanine, I think. Citrulline, I think, is another supplement that have been shown to kind of increase blood flow.
Yeah. How often do you subscribe supplements to people with ED? Like, do you? I know we've talked about this a little bit, but you try to make them do the lifestyle first, and they come back in and do it. Do most people that do the lifestyle change have to get on ED medicine?
So I would say, unfortunately, yes, and I think it's mostly due to changing your lifestyle is like the hardest thing ever.
Yes.
And I tell patients this. I'm like, look, I'm not judging you. Like, when this doesn't happen, I mean, this is, change behavior is like the hardest thing to do ever. And especially a lot of these things that we ask you to do, you've had, 20, 30, 40 years of really bad habits. It's not going to be something that just happens overnight. And And so I don't want them. I want them to know how important it is, but I think shame is not something that you need to do to these people. Like that, they already kind of feel it. They already know what they kind of need to do. I just think most people just need encouragement.
And that's one of the things that we like to do here, have this conversation. So when they do end up in your office, they have more tools to be able to talk to you about things, or their own doctors or whatnot.
Exactly.
Most people aren't going to sit here and talk about penis pumps and stuff like that.
Sure.
So I do appreciate your candidness with stuff like that.
Sure.
So
yeah, and I was going to just add, there's some people who will be so kind of maniacal about lifestyle changes that they won't do the other things. And I'm a big proponent of like, look, your testosterone's low. I think we can kind of jumpstart things. If you're low, let's replace it, and you do X, Y, and Z as well with that, and that's gonna be even better than trying to just do this on your own.
What's the length of somebody that's on ED? Is it just like is it month by month? Is it a 6-month thing? Is it a 12-month thing? Because I'm thinking in my mind, I'm thinking cholesterol medicine, heart whatever medicine.
It really depends. If it's an older guy, it's probably going to be a lifetime.
Okay. And that's a pill every week or whenever they do it.
Whenever they want.
Whatever it is. Okay.
But it is really surprising. I think a lot of times just with age, sexual desire, appetite, libido, it tends to wane. And so I would say a lot of my patients get to a point where it's just not that big a deal for them, which is sad, but I understand. I don't want to push it on them.
Yeah.
But yeah. And then the younger folks, I tell them that, this is real surprising too. I could go on a whole conversation about this. We're seeing erectile dysfunction in younger guys every year.
Why do you think that?
There's a number of reasons. We think maybe it's coupled to, we've also noticed decreased sperm counts. And there's a thought that...
maybe that's just Darwin?
Exactly. We think they're like hormone disruptors. We think, the real common one we hear about is BPA. But there's a lot of chemicals we think that we're being exposed to now that we weren't necessarily 20, 30 years ago. And that these are causing low testosterone levels and in turn maybe causing low sperm counts.
Energy drinks?
I don't know if there's been any association between that, but I do know that, those energy drinks often have lots of sugar. Yeah. And probably the worst thing for you is liquid sugar. It gets absorbed so fast, it causes your insulin to spike so hard, and
insulin resistance jumps in, and you're all sorts of messed up.
And then it just kind of perpetuates itself. So, yeah.
So stay away from liquid sugar.
Liquid sugar, exactly.
Okay, so urinary tract, you're urologist. Does any of those type of issues like make ED worse or better?
Not really. There's not really an association with them, but it is associated in the fact that it's more common as you get older. So the older a guy gets, the more likely he is to have urinary issues, and then the more likely he is to get erectile dysfunction.
And you said something about pumpkin seed oil earlier, right?
Yeah, so there's 2 natural supplements. There's something called pumpkin seed oil and then saw palmetto. There are others out there, that can help, but these are actually probably some of the more well studied.
Are they over the counter? Okay, yeah, pumpkin seed oil and saw palmetto over the counner to help urinary. Okay.
Yep, absolutely. And then there's a lot of other supplements that'll have things like turmeric and some other things in there that can potentially help.
Great. You're married. How many kids?
So his and her situation. So I'm on my second marriage. I've got 2 kids, and then my wife has got 4 kids. So total, we've got 6. So we've got quite the circus.
Yeah. Do you have a housekeeper named Alice? No?
No,
okay.
I wish. Definitely, my wife wishes.
Yeah, I bet, right?
So, yeah, we recently had to buy a new vehicle there that seats 8. I never imagined myself having a vehicle that seats 8 people, but...
Giant excursion or something, maybe even a small bus.
Well, so it gets weird, like Chloe's family, like they had one of those Ford... Econoline buses, basically a van,
big,
like
big
a
van.
13-passenger van,
Yeah, because we were talking earlier before the show, and your wife has like 7,000 siblings.
Exactly.
Okay, Josh, thank you so much for joining the show. Like you said, LinkedIn, they can find you.
Yep, LinkedIn, and just if you go to the Trios website, find a provider, urologist. I'm the only urologist there.
And go into the comment or the notes on the episode too. His information will be in there. Josh, thank you so much for joining the show. I appreciate you coming in and being one of the first guests in studio. So, hey, thank you, sir.
Hey, thank you much. I appreciate it.
Take care.
Thank you for joining the Invigor Medical Podcast. For more information on the show, Invigor Medical, or to get a hold of Chris, go to invigormedical.com.